Welcome to the GI Medicine Resident Series, Irritable Bowel Syndrome Diarrhea Type lecture. Today we'll be reviewing 3 learning objectives: understanding the diagnostic criteria for irritable bowel syndrome, applying red flag symptoms to guide initial workup for IBS, and reviewing first-line treatments available to primary care providers for IBS-D symptoms. Key points throughout the presentation will be highlighted with the key symbol. To review epidemiology and characteristics of irritable bowel syndrome, it is important to note that IBS is extremely common. Population-based studies suggest at least 10% of the North American population has IBS. This condition can affect all ages of patients and often presents in younger patients, less than age 50. Many more may not even seek care for symptoms, but we certainly do see a number of patients in clinic with irritable bowel syndrome. For symptoms and diagnostic criteria of irritable bowel syndrome, chronic abdominal pain is the hallmark of IBS. This is defined as at least 1 day of pain per week for 3 months to be considered chronic abdominal pain. It is key to note that pain is quite variable and may present differently in different patients, although there's often a cramping component and it may be relieved by defecation. The pain may also be worsened at times of emotional or physical stress. In addition to chronic abdominal pain, to meet criteria for irritable bowel syndrome, 2 additional features must be present. These are often focused on either pain related to defecation or altered bowel habits. The alteration can include constipation, diarrhea, or a mix of the 2. But to be diagnosed as IBS, the patient must have chronic abdominal pain plus either pain related to defecation and change in stool frequency, or change in stool form and appearance. For example, a patient with chronic abdominal pain newly having loose stools up to 3 or 4 times a day above a previous baseline of 1 may be considered IBS. Notably, mucus may be a common feature in IBS, but blood is not commonly seen in IBS, and we will discuss this more in the red flag section. Key components of a history to take in a patient with suspected IBS include medications. Medications may cause diarrhea or constipation, and it is crucial to do a good med reconciliation when a patient has new bowel complaints. In addition, family history for either inflammatory bowel disease, colon cancer, or celiac disease may lower our threshold for additional workup. Red flag symptoms to be aware of when evaluating for IBS include the following. Age of onset after 50 years may be concerning, that this is something other than IBS. Melanal or rectal bleeding should prompt additional evaluation. Nocturnal diarrhea is a key symptom to be aware of, because IBS should not typically awaken patients from sleep to need to use the bathroom. If patients are waking up overnight and having bowel movements, this may be a sign of something else happening. That is a key feature. Progressive abdominal pain or unexplained weight loss would also be considered red flags. If these red flags are present, it is reasonable to make a referral to a GI physician for further evaluation. The evaluation that can be done as a baseline evaluation in patients without red flag symptoms is limited. The key with this evaluation is to both be certain that we are not missing other conditions or other causes of symptoms, but also not to do an excessive evaluation that may lead to false positives. For evaluation of suspected IBS to rule out other potential causes of symptoms, we recommend blood and stool studies. Serum studies should include a CBC to rule out anemia, a CRP to look for inflammation, and celiac serologies to rule out celiac disease. Additional stool studies should include fecal calprotectin, a more specific measure of inflammation in the GI tract, and Giardia in those with chronic diarrhea. This workup is sufficient to do an initial screen for other causes of symptoms and provide a diagnosis of IBS if negative. There is no role for routine imaging or endoscopic procedures in diagnosing IBS. As mentioned, red flags may prompt additional evaluation, but this blood and stool workup is sufficient. For lab red flags present on this initial evaluation, that is also an appropriate time to refer to GI for further evaluation, which may include colonoscopy. Again, evidence of inflammation or new anemia would prompt that workup. If the patient ultimately is diagnosed with IBS, we then turn to a management phase. IBS management is focused on symptom relief, as this is a chronic condition and will likely last for the patient's lifetime. In particular, we can target either diarrheal or pain management in this case. If the patient has constipation predominance, then constipation management is indicated. For anti-diarrheal management, there are a few effective options. Dietary trials can be effective, although at times cumbersome to the patient. A dairy-free diet is often the easiest diet to undertake and can have a promising effect given the prominence of lactose intolerance in the general population. A low FODMAP diet has the strongest evidence for improving diarrhea and pain associated with IBS, but can be much more difficult for patients to maintain. Low FODMAP diet includes avoiding foods that have fermentable oligosaccharides, disaccharides, monosaccharides, and polyols, which includes many foods that patients may be eating. The full list of foods is beyond the scope of this talk, but can be found online with other resources. In addition to dietary trials, anti-diarrheal medications can be effective. Loperamide, or Imodium, can be highly effective and is safe to take on a daily basis for patients with diarrhea. While it can be taken up to 4 times per day, we recommend the lowest effective dose to allow patients to manage their diarrhea. Finally, rifaximin, a non-absorbable antibiotic that can help treat dysbiosis that may be contributing to diarrhea, is also an effective frontline therapy. This medication is taken for 2 weeks, 3 times a day, and if there is efficacy, it can be done up to 2 more times to provide additional benefit. Separate from diarrheal management, pain management is also a hallmark of IBS therapy. The dietary trials already mentioned can also have strong efficacy for pain, as reducing gas and bloating from these diets can lead to less hypersensitivity in the colon. Antispasmodic agents are also highly effective, or can be highly effective, in treating pain for IBS patients. Dicyclamine or hyoscyamine, otherwise known as Bentyl or Levsin, can be effective relaxants of the smooth muscle of the GI tract and can be taken on an as-needed basis or daily for abdominal pain associated with IBS. For patients who prefer a more naturopathic route, peppermint oil in capsule form or in a supplement called IBGuard can also be very effective as a relaxer of gut muscles. Finally, low-dose tricyclic antidepressants, such as amitriptyline or dizipramine, may also provide some neuropathic pain relief in the gut. All these medications are within the purview of primary care to provide, if appropriate. Finally, cognitive behavioral therapy can be quite effective as both an adjunct or a primary pain management modality. For patients who are able to access a therapist, this can be a highly effective tool. Putting together what we discussed, we've reviewed the Rome criteria for IBS, which includes chronic abdominal pain at least once per week for 3 months, and then 2 additional features, either pain related to defecation, a change in stool frequency, or a change in stool appearance. If there are alarm features, it is important to refer to GI for further evaluation. If there are no alarm features present, we reviewed a limited workup, including stool studies and blood tests, to look for anemia or inflammation that may also prompt a workup by GI. In particular, iron deficiency anemia or elevated stool markers of inflammation would be a strong reason to refer to GI. If this limited workup is normal, then we may begin to, and the patient meets, if the limited workup is normal and the patient meets criteria for IBS, we can begin a focused symptom-based management of their symptoms. Anti-diarrheal agents, including dietary trials or other medications, may be effective, and pain management is also critical for patients who are experiencing pain-predominant symptoms. To summarize, we hope this video has helped you understand the diagnostic criteria for irritable bowel syndrome, apply red flag symptoms to guide our initial workup for IBS, and we've reviewed some first-line treatments available to primary care providers that you can use when treating patients with IBS. Thank you, and please take the post-test after this course.